Good afternoon. Welcome to Grand Rounds today. Today it is my pleasure to introduce Dr. Selden Spencer. Dr. Spencer is a neurologist, a polysomnographer, and a neurosonologist. He has been a frequent and excellent speaker at Grand Rounds, and today he has graciously accepted our invitation to provide us with a review of headache. And please join me in virtually welcoming Dr. Selden Spencer. Thanks, Selden.
Well, good afternoon, and first and foremost, thanks for all who have come here today. Thanks to Tim Hextra and my colleagues in neurology for helping me put together this talk. And I want to just go ahead and get into it. Let's see here now. So I don't have any financial closures. I am going to use some case histories. They may or not be actual cases, so don't get too hung up on it, and names are changed and all the other things. So this is the outline of the talk. I'm going to talk about the nosology of head pain. Believe it or not, there is something to trying to categorize what kind of head pain you're dealing with. And then, of course, every talk always has to talk about the red flags. This is what you don't want to miss. You don't want to screw up on this. You want to be able to identify a person who has a headache that is a disaster waiting to happen. Every talk about headache has to go over that, and I will go over that. Then I'll indulge my own fantasy to talk about migraine pathophysiology, which is very interesting, and I know as a practical matter is not of any help to anybody, but it still sparks your curiosity, if nothing. I'll give you my clinical approach to headache and treatment options, and the case histories and historical sidelights will just be there to break things up, maybe to educate as well. So here's my first case, and maybe before you tune out on this talk, take the lessons from this case. 65-year-old man with a 1-year, and this is back in the 90s. This is a long time ago. I still have the egg on my face from this case. 65-year-old man came with 1-year history of progressive left-sided head pain. It wasn't episodic. He had good days, bad days, no precipitants that he could identify. It wasn't smells or lights or weather, and his exam is normal. The laboratory and CT of the head were normal. I gave him non-steroidals and acetaminophen. They were ineffective. He was mad. He somehow got seen up in Mayo Clinic. Are you ready for the answer? Diagnosis: left masseter muscle myositis. Do I think he had left masseter myositis? No. Was there ever a biopsy done of the left masseter muscle? No. Was his labs abnormal? No. But what I also know is I never examined his left masseter. So one of the subjects that I want to emphasize is it is worthwhile to examine the patient. It is worthwhile to examine the patient, to palpate the masseter muscle, the temporomandibular joint, the temporalis muscle. You're obligated to try and make a diagnosis. He got better with steroids and therapy. So the lesson from the moral is I learned from that I always examine a patient with headaches, and then you try to partner with the patient to sort this thing out. Because at the end, the patient is the only one that knows what they're dealing with. They have to describe what they're dealing with. They have to guide the diagnosis and treatment. So here is headache, miserable, documented forever. This is a nice artistic representation of pounding left-sided head pain with the devils eating them alive. And this is the nosology that I was going to refer to. This is 2013. And primary headaches and secondary headaches, and I'm not going to get into a lot of detail other than to emphasize there is such a thing as secondary headache, and this is what I encounter a great deal. The person has had blows to the head over and over again, and they have a headache. I can give you examples. One guy who works on a meat packing line got a blow to his head from animal carcass and broke his helmet and knocked him out. And guess what? He has headaches afterwards, and they don't go away. And so I think recognizing that everything walking in the door is not just migraine or tension-type headache or a trigeminal autonomic neurocephalgia, is worthwhile. And I cheat. I kind of say primary headache with, secondary headache with migraine characteristics. You can float those together. So this is a work in progress. I have attended headache conferences where 2 hours were spent arguing about a new diagnosis of headache called newly daily persistent headache. I have no idea if such a thing exists, but I know honest, earnest people are trying to sort things out, and it behooves you to pay attention to it and have some idea of coming up with a diagnosis of the headache problem. We'll get into migraine later, but just remember, migraine is not everything. So here's an interesting case, and a lot of these are just very recent. 45-year-old special ed teacher with a 4-year history of infrequent episodic left parietal pain that she thought might be a migraine. Didn't respond to Excedrin or over-the-counter medicines. But then in February of this year, she had a brief Bell's palsy. Bell's palsy is left facial weakness in this person, left facial weakness. And usually, most time resolves spontaneously after a month. This person's left facial weakness lasted only a day or two, so you're kind of saying, well, maybe this was a stroke or something like that. I don't know. Anyway, she didn't do anything about that because it all got better. But then in August, she had horrific left face pain. And this is more the trigeminal neuralgia. This is the staccato, pop, 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 and they just wince and they're hunched down. That's not migraine. That's not migraine. So here's this person with some migraine symptoms, with some trigeminal neuralgia, with left Bell's palsy. What the heck is going on? So all these tests were done, and now this person I did examine, and I palpated up on her left temporomandibular joint, and it was horribly sensitive, very painful. So what's going on? The dentist assures me all the imaging of the left TMJ was normal. I am not satisfied. Her symptoms were controlled with gabapentin, which is something you would use for trigeminal neuralgia or any kind of seizure medicine. But she's off to University of Iowa. Maybe somebody else can get some idea of as to why this joint is so sensitive. So let's talk history. Now, most of the time when you got headaches, according to hieroglyphics, in 2500 BC, you would tie a crocodile to the head and put herbs in the mouth. And that's how you get rid of those headaches. You good with that? There is hieroglyphics, and as you know, and I know you're all conversant in hieroglyphics, but that's read from top to bottom and then right to left. And as you can read along with me, if a guy comes to you with a bad head, no, I'm just kidding. This has been around for a long time and is an ongoing struggle. And what I emphasize in the first half of the talk is you don't want to get waylaid by missing a diagnosis. So this is, SNOOP is a mnemonic that you can use. It talks to the idea of systemic disorders, neurologic signs. Onset is new, and this is particularly over 50, and this is a nod to giant cell arteritis, and we get to see people in the audience that are very familiar with this subject. Thunderclap is a presentation that you don't want to, if it is sudden, slam them to the floor. That's not a migraine. That's something that you need to address very seriously. And then the P's are all these variables that are unique. If the patient tells you, no, it's only when I exercise, or it's only when I bend over, well, it's not a migraine. I mean, you got to think and try to figure out what this headache problem is all about. My take is the patient sick? Do they have fever? If they got a history of cancer? Then the headache may be something more than migraine. Neurologic signs, are they slurred speech? We had a patient I called from the emergency. Actually, it was a woman who was found down in her kitchen and was not talking altogether right, brought into the emergency room, and they found on her a slight trace of subarachnoid blood. She did not testify that she had a thunderclap headache, but again, sudden head pain needs to be considered. And we can go on and on. This is your worst nightmare. Just you're worried, then do the test and get the help and keep the patient close. All right. So this is a little version on that whole subject. This is a 22-year-old woman with pituitary problems and has had some asthma, but then over a few months she started having severe incapacitating occipital headaches. Every time she would cough, every time she would laugh. Otherwise, she can get around fine. She could eat, have bowel movements. It wasn't just strictly a Valsalva thing. It wasn't positional. It was with laughter. Not progressive, but limiting to the point that she does not want to laugh. Everything was normal except her MRI, which is as follows. You're looking at the posterior fossa here, and what are you looking at is a slight herniation of the brain into the foramen magnum. Now, Chiari is usually with 1 centimeter descent into the spinal canal. This was just half of a centimeter. You don't want to do surgery. I had this long conversation with the patient, and frankly, at this point, I have nothing to offer her other than don't laugh. I mean, when you strain and cough, you are going to increase intracranial pressure and cause a vague form of herniation. This is a picture of a subarachnoid hemorrhage, and similar to the lady that I just described to you, this is kind of the image she had, and she's a lucky duck because, as you well know, a lot of subarachnoid hemorrhages don't survive. Third die by the time 1 day has passed, or even en route to the hospital. But she needs inquiry and investigation. I'll talk, how much does a CT scan cost? If you're paying for it out of pocket, it's about $400. So if you have to persuade a person just to get some image, tell them to get the image. It's worth it. It reassures them. So this is my essential H&P. I want to know when the headache started. Does it localize? Believe it or not, patients with chronic headaches are not keen to say where it localizes. And then we get into this whole idea, how many different headaches do you have? And God bless David Moore, he is encyclopedic in reciting all the variations of a person's headache. I want to know the biggest, baddest part of their headache. And where does it localize? I take a big sigh of relief when they tell me it's episodic. Chronic progressive headaches are a nuisance and difficult and hard to sort out. But if it comes and goes, I'm more excited about the idea of it being migraine and that I might be able to help them. Is there a positional element to it, like coughing, or only when your head is down? And does it relate to sleep? Of course, this is near and dear to my heart. Guess what? You're not supposed to wake up in the morning with a headache. You all agree? If a person is waking up in the morning with a headache, that ain't normal. I'll give you a case in a moment, but why do you try to encourage sleep in a migraineur? Because sleep somehow relieves people of headache. For a person to wake up in the morning with a headache, you got to worry about bruxisms, you got to worry about increased intracranial pressure, you got to be worrying about obstructive sleep apnea, a lot of things. So now, in terms of the exam, you want to look at systemic variables. You want to be able to palpate the patient. This is my routine. I touch the temporomandibular joints. I have them open their mouth. I touch the masseter muscle. I touch the temporalis. I go after the carotid. I've had one person with a condition called carotidynia, which is an unusual argumented issue that's argumented about. Trapezius muscle is going to the back, base of the skull. The occipitalis is about an inch or so above the base of the skull. You look at the mouth and look at the teeth. Look at the eyes. You don't have to do a fundus. It would be great if you could do a fundoscopic exam and be reassured by the optic nerve, but if it's a 60, 70-year-old person, your pupils are going to be small and you're not going to see in there very well. Check out the neck mobility, mental status, mobility, and balance. So this is just another curious case. He approached me, and this was not in the office. This was out in the neighborhood. and he was very anxious. He had 1 month history of headaches. I didn't really know him very well, and he's already seen us. So I said, "You've seen your doctor?" And he said, "Yeah, he gave me non-steroidals, and they helped, but the headaches were getting worse." Now, what was characteristic about these headaches? They were a global pounding headache that would awaken him every morning. Again, waking up with a headache is not normal, even though the ICD-10 does talk about morning headaches. I would say, caution you, anybody waking up with a headache, you want to pay attention to that. So I gave him a little piece of paper saying, "Get CT scan of head," and gave it to the patient. And of course, he had a posterior fossa tumor. And of course, I was a hero, of course. But no, the point of the matter is, you take a person very seriously. I mean, if you can imagine a teenage boy wanting to talk to an adult male, you know, this guy was desperate. He was desperate, and he wasn't getting better. His family didn't know what to do. The doctor had said, "Well, you know, take the non-steroidals, you should get better." Everything turned out fine. You know, wake-up headaches are always a worry for mass lesions, especially posterior fossa. Intracranial volume increases during sleep, leading to pain and nausea. Teenage boy approaching casual acquaintance, something must be going on. He did well with surgery, best there, I'm shocked. Okay. So now we're talking about head surgery and trephinations, okay? This is just your historical highlight, and starting with the skull in the middle, this is actually earlier than Egyptian time, and what is particularly interesting is that there was bone regrowth, so people survived trephinations. And now I do have a question to the audience. Why does the surgeon have a cone on his head, and why is the nurse looking bored with a red book on her head? Anybody figure that out? Maybe tell me something there. And it's not just Western European. I mean, it was true in the Middle East as well. Trephination and craniotomy for headache and other neurologic things was common. So now we're going to talk about migraines. And the ICHD definitions are helpful. Hemicrania was described by Hippocrates, BC. Left-sided or unilateral headache, and then the whole hemicrania was translated by French into the word migraine. This is a very common problem. It's ranked number 6 by the WHO as far as a disabling malady. In the United States, 18 to 6% of men, 18% of women have migraine. 1 in every 10 adults aged 18 to 44, roughly 39 million people. And furthermore, the cost from migraine, at least in 2003, was $19.6 billion in the United States. It's a very costly malady. One of the top 5 reasons for a visit to the emergency room. I see all the paramedics here. I think you would attest that headaches are a common problem, maybe quite often migraine. This is the ICHD, going back over this again, and I'm not going to... We're going to talk about aura very briefly, but believe it or not, migraine with aura and without aura are different conditions. Aren't you happy about that? Make life more complicated. But this is the criteria, and this is what I do very briefly, and you can do very briefly in the office. Now, okay, the person's already been here for his diabetes and hypertension. Are you going to spend another 5 or 10 minutes trying to sort out the headache that they threw in at the end of the visit? Probably not, but you can have them come back. You can ask them, so does it have a location? Is it more often on one side or another? Is it pulsating? And I get to it very quickly. Does this knock you out? Do you get this headache problem and just have to disappear? That's very powerful evidence for it being migraine. If you can throw in the idea that they have nausea or vomiting with the episode, and have sensitivities, that's very supportive. If you get those 3 elements, I'm inclined to think about migraine as playing a role in that, in their headache problem. May not be the sole reason, but is playing a role. And this is the classic migraine with a premonitory element, neck pain, yawning, food cravings, then the aura, which may or may not happen, then the horrific pain, and then the post-drome, where they just feel wiped out. And we could do a whole talk on auras, but just go over the scintillating scotomata, a little spot in your vision that just grows and grows, 4 minutes, 6 minutes, sometimes totally consuming the vision. And then it's normal several minutes later. And this is your historical reference to Hildegard of Bingen and her migraine auras from which she drew religious significance, the fortification spectra that she talked about in her essays. This is 1180 AD. And I found this just recently, and of course I did not read but I just like the term. This is a physician in England from 1873 talking about nerve storms. And I like that. That's a nice way of thinking about migraines. And now we're going to talk about my version of migraine pathophysiology. You have an unstable trigeminal system. The inputs are varied, but your task is to identify them and control them so you don't have an attack. If you get enough inputs, then they will just force you to shut down. If you have an attack, we can try things to abort the attack. If you have 4 or more attacks a month, you need to try to calm the unstable trigeminal system. This is a far more elegant. I know Dr. Goldsby, and he is well recognized in the world of headache and migraine. You can skip to the bottom line here. A disorder of sensory processing. The patient asks, why do I have this? Well, you have a disorder of sensory processing in your trigeminal system, or your vestibular system, or your olfactory system. So I'm going to read it because it is very complex. And bottom line one here is lots of time migraine is hereditary. It is genetic. And it's a disorder of brain function, the afferent pathways, nociceptive neurovascular afferents that seem designed to warn, not localize, projection to the thalamus and cortex, and the regulation of this pathway provide an understanding of complex symptoms. It is most likely that the many ideas surrounding this pathophysiology are relevant from a genetic, brain hyperexcitability, peripheral central sensitization, and brainstem hypothalamic dysfunction. More than you wanted, but remember, a disorder of sensory processing. And here's the circuit that you don't want to see, but at any rate, the neurovascular part to the trigeminal ganglion. Now the sensory part is coming into this ganglion that is sort of bipolar. It sends it off, and here is where the action happens. Back in the trigeminal caudal complex. And then going rostrally to the periaqueductal gray, which is all about pain, hypothalamus, all about nausea, vomiting, on up thalamus, saying, well, we're going to let these pain signals go through or not. Okay, now here's the bottom line. I think one of many bottom lines. A migraine brain is not the same as a normal brain. Okay? Anatomically, they are different. What is cause and effect, I do not know, but you will see atrophy in the gray matter in very selective spots in migraine brain. Cerebral blood flow during migraine attacks is very specific and complex, and physiology is abnormal during the attack and between the attack. If you had a normal person, it would just be a single straight line across here. This is stimulating the trigeminal system and recording oxygen extraction in the trigeminal nuclei, and it's all over the place. The attack occurs 16 days after the previous one. All I want to say is there's instability. Now, I know you really like this slide because this has got all these different anatomical locations in the central nervous system, and it has all these receptors and all these chemicals. And I'm going to tell you there's absolutely just one chemical and one location in the central nervous system that controls all of this. That's not true. The point is, this is a shout out to the 2021 Nobel Prize of Medicine, which I have to read the names, David Julius and Ardem Pataputian were awarded the Nobel Prize in medicine from a neurobiological perspective. They established that a pressure on a neuron will create an electrical signal via selective genes and a selective protein. Myriad of opportunities just like this, and they were able to hone down on something very specific. So possibly there is some hope in the future that we'll understand more detail about how migraines happen. So the migraine brain anatomy is different, as I mentioned, and make it even worse, migraine with aura anatomy is different than migraine without aura. Blood flow studies are abnormal. Connectivity stories, so we look at the white matter. They emphasize pain circuitry. And this last visit, I talked about the physiology. This is the part that is really more unnerving, that metabolic studies in the migraine brain are different than the normal brain. There is a condition, and I know you all know it, MELAS, mitochondrial encephalopathy with lactic acidosis and stroke and migraine. So this is the nidus where there is a lot of interest in the world of neurology about mitochondrial disorders being the source of migraine. And there's evidence through imaging studies that is the case. Very nonspecific, it's not localized to a single part of the circuit. So again, unstable vestibular systems, because you're going to now talk about vestibular migraines. You can imagine this research, this is from Germany. What they did is they subjected migraineurs to watching videos on a roller coaster ride versus normal people. And guess what? Migraineurs had a horrible time. And any pediatrician will tell you motion sickness in children is a common precursor to migraine experiences. So we could do a whole talk about genes, and this is in my career that we have established that one migraine condition does have genetic basis. Familial hemiplegic migraine. That is, you have the horrific pounding head pain and then left-sided weakness. That all makes paramedics very happy to hear about that. I have patients that are admitted repeatedly to hospitals and go through big stroke workups. They have hemiplegic migraine, and you can do the genetics and you would find the gene. And that's new, and that emphasizes, there's another one that is related to circadian disorders. At any rate, there is a genetic basis to migraine. So here's another case, 34-year-old man, and again, a very recent. He has autism, he has ear surgery, got worse, balance and dizziness that would come and go the past year, no medicines or illness or systemic disorders. And then via telemedicine, I was asked to see him after a well-respected ENT physician suggested this was vestibular migraine. And this is where all neurologists give a big eye roll and say, do I have to see this person? But anyway, I did. And of course, it's very limited. It's telemedicine. Everybody was anxious, and he's an abnormal exam. His eye movements were very abnormal, but he said, this is not new. Speech is normal. Labs, imaging were unchanged. Vestibular migraine, let's just give a flavor. You can do an exam and just look at eye movements and say, wait a second, there's something not right here. But I got to the end of my exam or my visit with him, and he said, well, what are you doing now? Well, the ENT doctor had placed him on 400 milligrams riboflavin, 400 milligrams of magnesium daily for 3 weeks, and he was doing better. Are you better than you were before? He said, yes. So I said, I think maybe he's right. Let's leave it alone. If something's working, don't screw with it. Run with it. I will get more on riboflavin later on. But your next historical vignette is from 300 AD in Rome, where we started to get pharmacological. And I'm not sure whether she has an axe or a fan, but at any rate, he's suffering a migraine and getting a poultice of opium around his head. So migraine treatment, just keep it simple. Try to prevent. If there are circumstances that cause migraine, stay away from them. Now, obviously, if it's, and people are very smart about that, they will avoid the odors and fragrances that cause their headaches, and foods. Abortive therapy, we'll go over this in more detail, but I think I have a nice, a little JAMA referral that is absolutely encyclopedic. This is kind of Mayo Clinic folks that take every article that was written on the benefit of triptans versus GPANs versus NSAIDs and looked at their virtue. Then I always add in that it's probably best to calm the stomach down so that if they're taking an oral medicine, it gets absorbed. If they're nauseated and throwing up, what you put in the mouth isn't probably going to do them a whole lot of good. And there are all kinds of versions of sublingual, nasal, subcutaneous treatments working with triptans for abortive care. Preventive is beta blockers, calcium channel blockers, tricyclics. Mike Kitchell and Don Skinner have stuff in bare bones on Epic System, which will go into great detail on all these options. I threw in the riboflavin toward the end here. And I just wanted to do a little quick shout out for neurotransmitters, which are mainly focused on serotonin. And I don't want to go into this anymore because all the interest right now is on calcitonin gene-related peptide, which is not considered a classic neurotransmitter by any means. And the world of neurology and headache have focused a lot on substance P, and for some reason, calcitonin gene-related peptide was ignored until the last 10 years or so and is now being exploited tremendously. I just wanted to say that there's a lot of different drugs being developed and worked with and working with different neurotransmitters. And there's a lot of different locations that you can worry with. So now I do want to emphasize a little shout out to CGRP in honor of Serena Williams and Kardashian, who are advertising these products very heavily. The GPANs are basically the acute abortive treatments which are going after the calcitonin gene-related peptide and will block it. The calcitonin gene-related peptide monoamine antibodies will block the receptor so that the CGRP can't activate. And I like this slide because it shows three things. One is, yes, it has something to do with nerve transmission across the synapse, but it also affects directly to muscle surfaces, and more importantly, to mast cells. So the whole idea of neuroinflammation associated with migraine is a reality. And in fact, there's imaging studies through a version of PET that show a migraine brain has more neuroinflammation than a normal brain. So a lot to learn from that, and it's an effective drug. So abortive treatment, it's more detail. I gave you the reference up higher, which is better than what I got. This is my take. Obviously, you're going to go for conservative non-steroidals to begin with. The triptans are wonderful. They are serotonin active and do affect cardiovascular systems. If there's nausea as the early onset of their migraine, you need to have them treat the nausea with a dancerone or whatever. Lasmidan is a new one that is a serotonin drug active, but it also comes without all the cardiovascular side effects. GPANs, limited by cost. The bad boys like Fiorano still work, but they're prone to abuse, and you try to stay away from those. So it's Friday afternoon. For 30 years, I get a call Friday afternoon. My headache's horrible. You take Vistarol, you take Phenergan, go to bed. Sleep will relieve your headache. Or go to the emergency room. Call the paramedics. Have them take you to the emergency room. So preventative treatment. I just like to emphasize that these are, you won't be seen by neurology if there's a strong implication that you have migraine and you have not tried some of these preventative drugs. And, you know, like I said before, if you're having 4 events that are incapacitating a month, you need to prevent this. You got to get it down to 1 or 2, and nobody's going to, you know, do perfection. And I always look for a twofer. If you got somebody who doesn't sleep very well, use a tricyclic antidepressant. If you got a person with hypertension anyway, play with the beta blockers and calcium channel blockers. Do the best you can. And if they're if they're overweight and want to lose weight, they can try some topiramate. If they're not somewhat depressed, use some valproic acid. And I talked about magnesium and B2, very safe, very simple. And the CGRP antibodies that are on the market, very expensive. We can talk about Botox, we can talk about electrical stimulation, and great, I'm getting toward the end of the talk, and I'm going to make it here. All right, so I like this case. This is, you know, again, drawn from recent interactions because it points out a lot of things about migraine. This is a 22-year-old man who has an apartment, job, girlfriend. He's been dealing with migraine since he was 11. Missed school, got into trouble at school. It was more of a bitemporal pain with vomiting. Very strong family history of migraine. Nagging, recurrent sinus affection, joint laxity, especially with his neck. So he eventually was diagnosed with Ehlers-Danlos syndrome. And, you know, your mind can say, well, maybe if he's slipping around with his neck, he's getting pain, and those signals are getting magnified. Anyway, he never has aura, but he does know when he's getting into trouble. And he's been followed with neurology for 2015. He's been through everything. Now, admittedly, he does like his Mountain Dew, and he doesn't sleep that well. But his mother made him sure he tried the tricyclics, he tried the beta blockers, topiramate, Depakote, and CGRP blockers, no benefit. Sometimes benefit from Phenergan, which is more of a dopamine blocker. He works with heavy equipment. Feels like if he keeps mobile and doesn't stare, he will not get a migraine and be incapacitated. Especially important for him to keep the same sleep schedule. There's this old legendary thing about work letdown headache. He cannot sleep in. That's a bad thing for him. He has to keep the same schedule. I always tell my patients, in many respects, you got to be like white bread. You got to do the same thing day after day, day after day. And he's not really had great success with abortives other than some caffeine and sometimes sumatriptan. And he's down to maybe 2 incapacitating migraines per month. Everything's been normal. I just say, go with the flow, keep it. He says, you know, I just want my sumatriptan renewed. You know, okay, we're going to stay with that. You've got the problem under control. So now we're going to talk about Botox and refer immediately to the Battle of July 30th, 1609, where Samuel de Champlain with the Huron Indians blew up the Mohawks. And the problem with this battle, and Lake Champlain is named after the explorer Samuel de Champlain. The problem with this battle is that General de Champlain got a migraine at the end. And the Huron Indians knew what to do. They jumped in the water, got a garfish, and cut the head off and scraped his head. I think this is a precursor to Botox in my mind. So Botox, conceptually, this is a deafferenting process. Now, you think about Botox as something that relaxes muscles, you know, makes a muscle weak. Botulinum toxin is considered a lethal problem in terms of ventilatory and respiratory behavior. But in this circumstance, you're using tiny doses in specific muscles to deafferent those muscle inputs to the trigeminal system. And it's actually through the vesicles inside the neuronal cell that are impaired by Botox. And it comes back, everything reestablishes in 2 or 3 months. So anyway, you hit the corrugator, procerus, frontalis muscle, temporalis on both sides, the occipitalis, the paraspinous, and the trapezius muscles. 31 shots, small, tiny little bits, and I'm a believer. I think it works. Doesn't work for everybody. Here's a case. I've followed her since 1996. 6 events per month. This is before Botox, all kinds of preventative treatments. I'm going to dish off of this in a moment, but very poor sleep. She has obstructive sleep apnea. She has bruxisms. Sometimes gets benefit from one of the triptan varieties and Excedrin. And previously, she was going to the emergency room maybe 2 or 3 times a year. 2013, we considered Botox. She now returns this is 30 times, 30 plus rounds of Botox. No visits to the emergency room, 4 to 5 disabling migraines per month, but just not as severe as before. So I don't know. This is success. This is my world. And I'm going to continue as long as she wants to go with it. Now, where I wanted to dish off this is I almost wanted to put in another case. I had a patient that I saw who had a headache every day during the week around 4 o'clock in the afternoon. What the heck was going on with her? And I tried her all kind of medicines, and they were very, very aggravating, very, very troubling. Anyway, I saw her for maybe a year, you know, every month or every 2 months, and then I didn't see her. I said, well, I guess she got better. Well, I ran into her in a grocery store somewhere, and I said, hey, how you doing with your headaches? He said, oh, I don't have any headaches anymore. I said, well, why? Well, I quit my job. Turned out 3 o'clock every afternoon, the boss would come in and just rake her over the coals, yell at her, throw things around. Social situations can trigger headache. And I think patients are very mindful of that. If what they're doing, if their lifestyle is horrible, they got to correct their lifestyle. And if it's a marriage, it may not be that easy to fix, but keep your options wide. Okay, so electrical devices are trendy now. You can go after the trigeminal system through the supraorbital nerves, the occipital system through the occipital nerves, and the vagus nerve, and they work to some degrees. I was at a meeting and I got to try it on. It gives you a nice little Wonder Woman vibe, but doesn't go that far, I guess. So I'm kind of to the conclusion. I think take headaches seriously, snoop around. You don't want to get burned. Always give the patient the benefit of a doubt. If they are desperate, you try to figure it out and make sure there isn't something anatomical going on. Engage the patient, avoid passivity. There's a trend in medicine that I know what's right, you don't. Don't go there. The patient is the only one that knows what they're suffering, and they have to be able to communicate with you and guide you in your diagnosis and care. I didn't talk about calendars, but that does empower the patient. And then try to determine what kind of treatment they would like. Eliminate variables that can be contributing: poor sleep, bruxisms, neck pain. Need a plan, preventative treatment, and abortive treatment, and keep an open, inquiring mind. Now, I do have some afterthoughts. Given that we're going into climate change and we'll go from a nice green pasture and blue skies to some barren situation, and there'll be a collapse of civilization. And we're looking at Lamageddon and the apocalypse. Perhaps someone will find my photoshopped image on a papyrus in 4529 and say, they were doing the Egyptians were doing some interesting things in Iowa back then. Anyway, that's for your amusement. I'm all done, and I'm happy to entertain a few questions, and I think I'm going to need Tim to help me with there. Are you impressed with my computer skills? I was able to do that. All right. Now we're all done here. And here I am. Come on. Some people in chats outside are, oh, okay. All right. Dr. Gerbrock, please. Well, I hope, I was talking to Dr. Hallberg before, and it is true that every 3 years, one of us tries to give a talk about headaches and migraine, and please be, and I think Hallberg is always kind of amazed and amused that half of what we do in neurology is headache, in my opinion. I mean, we'd like to think we're all about peripheral nerves and epilepsy, but headache is a huge problem. And if this talk has been of any help to you in your management and care and empowering patients to take care of their headache problems, it's all good. So Tim, I'm waiting. Tell me what to do. At what point is a neurology referral acceptable? Oh, I got it. All right. So yeah, the standard thing, and this is courtesy of Mike Kitchell, my partner, is that, and also Dr. Clements and Dr. Ramage, we really want to know that the patient has had some kind of image of their head, that they have had some trial with treatments, either abortive or preventative, and some of us are more dogmatic than others. Mike really wants to see them try 2 preventative drugs. And as I mentioned before, this is all outlined through the University of Iowa and through Don Skinner and through Mike Kitchell in bare bones on the EPIC system. Now, if you have a concern that this is not just a chronic headache that has been going on for 10 or 12 years and is getting worse, we'll try to get you seen earlier. But again, you'll need to do some kind of imaging and give some trials of other medicines. And it's tough. I mean, I remember going outreach in Carroll, and there was one primary care doctor out there who just didn't want to deal with headaches. Boom. Patient said he got a headache. Well, you got to see a neurologist. And that's understandable, but also not very helpful. Long term, you have a primary care patient, you need to give some legitimate effort in sorting out the headache problem and offering a treatment, and getting rid of any concerns of awful things that can occur and manifest as headache. I think, so I'm waiting for Tim to tell me, oh wait, here we go. Waking up with a headache, not normal, but is ever, AG, sleeping? Yes. Yeah, here's the question. Waking up with a headache, not normal, but is ever simple, IG, sleeping in the wrong position? Absolutely. And that's, and I didn't give a shout out during the talk, and I usually do, about peripheral pain mechanisms. As I mentioned, bruxisms are not uncommon, but let's say you are sleeping in an abnormal position. Maybe you do have problems at C1, C2. Maybe you do have problems with your occipitalis nerve, and getting all cranked in a wrong position could easily trigger a peripheral problem, which then secondarily is causing headaches. And here's, so yes, sleeping in the wrong position can cause a headache, but if you can understand why it happened, then you're done, that's fine. Don't sleep in that position. Okay, what imaging modalities do you prefer for particular presentations? Unless you have something, you know, so I showed you an MRI of a modified Arnold-Chiari malformation. That's probably the root of this person's problem. You would not see that on a CT scan. And yet, getting an MRI for a headache is very difficult. I think at a first pass, I think a CT for non-specific pain that is going on for a month or two is very reasonable. I'm not going to see them unless that's been done. And if it hasn't been done, I'm going to order it. And then I'll have the wrestling match of trying to get an MRI approved, because the MRI is superior to the CT in all forms. And so now I don't want to confess to fraudulent behavior, but I will find a way to get an MRI done. I would prefer an MRI, but at least bare minimum $400 CT scan of the head for a headache is reasonable. Get it done. and it can be done without contrast. You know, you do that and things continue to decline and they change. Stay tuned, like the other patient I talked about with the Bell's palsy, now with trigeminal neuralgia. You got to go further, you know, and imaging with MRI was very reasonable. Unfortunately, it didn't show up anything. Thank you, Dr. Hallberg. That guy's standing up, so he has a question, I'm sure.
No, I'm falling asleep.
Okay. Honest. Very good. Well, I think if I have permission, I will. Yeah, it's 1:06. I think I can close it up. I want to thank you all for being here. Have a good day, and give me a call if I can be of any help to you. Okay, bye.